Muy buenas tardes.
Good afternoon,
Señoras y señores,
ladies and gentlemen.
les damos la bienvenida al liderazgo
Welcome to
webinar
webinar
de liderazgo de enfermería y
on
innovaciones tecnológicas
nursing leadership and health innovation technologies, organized by the School of Nursing at the Catholic University of Chile and UC Christus Health Network. I'm Carla Ramos. To give you a bit of context, I'll be the moderator. I am a nurse, master's in public policies, and finishing a medical IT degree as well. And I'm a research coordinator at the Catholic University of Chile, PUC. To provide a bit of context of what we're doing today and what we've gathered here for, and in terms of the relevance of information technology, IT, and innovation, we can provide a wonderful example, which is our country, and to somehow understand the national territory and the inequalities that are present vis-a-vis inhabitants. From that point of view, looking at all the coordinates or nodes, so to speak, we're dealing with populations such as the Araucanía, the southern region, particularly the city of Temuco, where 30% of the rural population has scarce access, even for basic services such as health, where physical access is difficult due to the rurality. Now, the challenge for us, and which lies ahead for you as well, is how to bridge that health gap, how to access that group of women, for example, with gallbladder cancer, highly prevalent in Chile, who can't have timely health care at hospitals because, for example, they may live very close to the mountain range with a 4-hour drive to the city. That's the challenge. Therein lies a challenge. How to use IT and all the tools we have now. How can we improve and give more dignified healthcare? That's why we have these guests with us today, and I'll be guiding us through our topics in this dialogue, where we'll be looking at the role of leadership in nursing based on IT. I'd like to greetings to our speakers, the sponsors, and the members of UC Christus and the public at large. Thank you for being with us. We're also being broadcast on YouTube from the School of Nursing of the Catholic University of Chile. Before kicking things off, I'd like to give you an overview of the dynamics of this webinar. As far as language goes, this will be streamed live in Spanish, and Nurse RN Honey will be translated into Spanish. At the end of this webinar, we'll have a completely English version, which will also be available on the YouTube channel for the nursing school for a limited time. With regard to the questions and comments, Q&A, during the round of the talks, you can relay through the chat bar in YouTube, the comment bar, your questions and our comments, and our team will be looking over, screening the questions and relaying them to us as they see fit. Upon wrapping up the talks module, we'll have a space for fielding questions and for any comments that you may have. So, without further ado, we'll be beginning our speakers panel by introducing RN Viviana Torres, Masters in Medical IT, head of the diploma program of clinical IT at the Catholic University. Her talk is on the role of leadership based on technological innovations. Thank you very much, Viviana, for being with us today. And the floor is yours. I'll be giving you that 2-minute grace period at the end. Thank you very much, Carla. Thank you for having me. Thank you for the faculty for having me. Good afternoon to all that are tuning in, and for Michelle Honey, Dr. Michelle Honey, correction. And it's bright and early over there in New Zealand. So my presentation, as mentioned, is the role of leadership based on technological innovations. Carla already introduced me. I'm a nurse, master's in medical IT. That's what I'm devoting myself to. I've been doing it for 10 years. Very fascinating for me, looking at the progression we've had, the growth over this time in this area. Now, just to give you a bit of context, first we'll be looking at digital transformation in healthcare. Now, this involves certain aspects that I'm breaking it down to 3 points. First, this involves the incorporation of technology, which is through transformation of healthcare. Technology will allow us to improve our processes and to transform the healthcare that we're providing, our services, when it comes to patient care. This also involves a cultural transformation when looking at digital transformation, which is important because this cultural transformation is for all, not just for those who implement an IT system. It involves the entire organization, the ones who see patients, people who admit patients, and the people who finally see them. This digital transformation has to be based on people-based, which is the most important aspect. This also involves the creation of new ecosystems and ways of working. And to that end, we need a lot of adaptation capability when incorporating technology, which will be changing the way we work currently. I'd also like to mention some technological changes at the forefront in the digital reinvention of the industry. This can be summarized in this curve you can see on the screen. A lot of information here. It's quite complex, but I hope you'll understand it. Now, the curve would be exponential disruption of accelerated obsolescence. Now, what does that mean? There's an exponential disruption of technologies when they appear, when they arise, but after a few years pass, these technologies become obsolete over time. So you have a lot of technologies that come out and after a while become obsolete because this digital transformation is going up exponentially in terms of advancements. We're looking at the technology we have at hand. There's already a new one coming out on the market, modifying our learning curve in terms of evolution in technology. Now, here we are in point 5, big data, which is in vogue and which has experienced this exponential growth, analytics, visualization. Finally, 6, Internet of Things, IoT, and smart machines that use internet as a base, as a foundation for providing better care. This is very important for us to understand, to be aware of. Technology goes so fast. You can see that a lot of things become obsolete in the short term. So we have to jump on this train in order to keep up to date with the new technologies that are coming out. In terms of digital transformation, here's a quote from Albert Hubbard. The world is moving, which is to say mainly, as I was saying in Spanish, translating it, we're moving so fast nowadays that whoever says something can't be done is usually interrupted by someone who's already doing it. That's what we've seen in the curve, demonstrated in what I've just shown you, with this exponential growth, with so many things becoming obsolete, with new arising technologies or emerging technologies. Now let's get a bit more specific into into nursing. Now let's look at some technological advancements in the industry. One area is retail. We all buy over the internet, make purchases, shopping lists. We can even receive a delivery at home of what we buy online. This is driven, obviously all driven by retail. Now, in terms of banking, we've seen technological advances in the last few years. Who would think that our grandparents would never imagine a few years ago that we'd be doing transactions, paying bills, and managing our finances through our phone? and even in a safe manner. Now, practically everyone uses this modality. We've also had important progress where machines are controlled by a central station, and transport and machines that use data mining from a distance. Even as it pertains to physical mining, mining is also controlled by machines. Even in agriculture for plague control, risk management, almost anything having to do with agricultural practice at large. But how are we doing as it relates to healthcare? Now, we have certain systems of health information which are already well established, which have already come out and are available for general use by us as clinicians. These would be the main information systems in health that we'll be dealing with. It's important to get to know them and recognize them, not just by their acronyms or their initials, but to see how they'll help us. I won't be going over every single one, just to represent everything we're in contact with or will be in contact with health information systems in clinical centers. These information systems in health, it's important to point out, as Carla mentioned at the introduction, is that we have implementation at the national level, which is quite dissimilar and non-uniform. There's a difference between the public and private sector, where the public sector doesn't have that many advancements in the implementation of information in the health, and the private sector, there's a bit more progression in that area. Either way, we're still not up to date when compared to the rest of the industry. We're still a bit behind, where everything is done through smartphones. But in the healthcare area, we need that empowerment, that drive in terms of use of technology for improving healthcare for our patients. So we asked ourselves how to innovate and remain competitive in times of accelerated change. The important thing about this question, and be able to answer it, is to look at the role of leadership that we have as health professionals, such as nurses, within each clinical center. You should acknowledge that nursing shouldn't be distant from the progress of information advancements and should use them to evolve at the same pace that these new technologies. We can't start using technologies, come up late, and they'll already be obsolete. And that's where that graph of exponential growth and obsolescence comes into play. We can't be left behind when it comes to the healthcare of our patients. Now, as nurses, it's important to take on our leadership role within the clinical centers. Why? Well, we have to make the most and bolster our talents and abilities in research in our area of knowledge, and to bolster the tools we have at use for creating value for our patients. Now, this is something we all know as nurses, and we might know intrinsically, but not explicitly, is that nurses are a central node in terms of healthcare. Every day, we lead, guide, conduct, and understand. We know where the systems aren't working for patients and where these needs aren't being met, because we manage all of the processes within a hospital or a healthcare center, primary healthcare. So this is something we have to bolster. We have the practical knowledge. We're constantly assessing for ongoing improvements, and it's important to foster it. So it's important for science, technology, knowledge, and innovation. These have to be known as transforming key agents when it comes to attaining sustainable development and comprehensive development, which are key for raising productivity and driving our growth and contributing to improving quality of life of our patients. Now, the use of information communications technology are a strategic element of support for our health system that has to be adapting constantly to new environments and needs. This ICT. It's important that as professionals, we have to be moved by quality, innovation, and ongoing improvement as often as we can in order to improve patient care. Gone are the days of traditional care from years ago, because now we have technological tools which allow us to provide better care to our patients. That's where we have to take on a leadership role in terms of how to move forward these technologies to make the most of them. And the benefit for patients as well, how to boost this. So when looking at leadership, it's important to have empathy, commitment, knowledge. All those three together can lead to an empowered nursing professional. All the tools necessary to take on the leadership role and boost information technology use in healthcare and to embrace innovations in this area. In terms of innovation, it has to be seen as looking for new forms to better attend to the needs of our patients. That's the end point from innovation in health. What does a patient require that still does not exist, and that's something that we have to create in order to respond to that need? We can only innovate if we're capable of changing our work styles, of treatments or health outcomes. It's not just the incorporation of new technology. Innovation is the ability we have to adapt, to change those work styles by using those new tools. Now, ongoing training and ongoing updates or renewal of the professional for the use of these new technologies for the development and the application of new healthcare procedures, not just in the clinical aspect, but when using technology. We can't be behind in technological know-how. We need constant growth and updates with that. Now, technology is just the intelligent tool that allows for innovation. The technology itself isn't the end point. It's the tool, it's the means to that end. It'll allow us to improve care for our patients, to improve the established processes. To wrap up, here's some final points on what the future of health holds, healthcare. At the national level, hopefully we'll have better connectivity and interoperability of data. What does that last part mean? Communication between different information systems in healthcare, for example, the electronic medical chart with a laboratory for there to be communication between them, feedback, to not have to transcribe results of the exams from one end to the other. We're trying to, and all the red tape. Now, in terms of the future of healthcare, these different systems that are a part of a clinical center, for them to be communicating amongst each other. There's a lot of relevance and in terms of artificial intelligence or AI. Hopefully using a lot of data, such as big data. Hopefully in the near future, so as to be able to perform predictions in terms of healthcare that we provide for our patients as nurses. In the United States and in Europe, a lot of studies have been performed with AI. They've been able to put together algorithms which allow to perform analyses of cancer, melanomas, for diseases which are associated with imaging data using AI. Now, we can do that, but we need high quality data. So it's our responsibility as nurses and clinicians who will be dealing with the digital charts to use them accordingly, not to input data where it's not needed, where it says blood pressure and you don't write it down there, you write it down in the free text area, in the comment section, for example, in its established area. We need more standardization. And another aspect of this would be, with AI, would be data analytics. Another thing we can see in the future of healthcare would be the Internet of Things, IoT, and wearables. Wearables are devices that are hooked up to a mobile health network where we can download applications related to health, for healthy lifestyle, nutrition, among others. Another area would be robotics. In the United States, we've had robots for even for clinical care, where they provide aid to the patient. It can receive feedback if the patient is feeling good or not. The robot can actually go to the nursing station and relay that kind of information. Now, decision support systems will be needed that are more sophisticated and complex will be coming out, which will aid in our clinical decision making in order to avoid errors that are made due to high demand or workflow or for a mission. And training and revision is always important for technology. There's a lot of supply for that. People who get diplomas in IT. The one that I run is from the Catholic University, which looks at clinical IT, which looks at all the trends in the IT as it relates to healthcare. So revision and ongoing training is very important. So this will be a part of nursing when it comes to leadership in the future. This has been my presentation. Thank you very much for your attention. And I will be at the round table. Thank you very much. Thank you very much, Viviana. Very interesting, your presentation. Hopefully this will be food for thought for the participants for the Q&A session, because not all of us are experts in these new arising, emerging topics. Now we'll have Dr. Michelle Honey, Master in Nursing Science and Program Director of the University of Auckland, New Zealand. The talk will be on how to implement a telenursing model. So the floor is yours. Thank you very much. You may begin.
Michelle, I can't hear you. You are mute.
Michelle, you appear to have your microphone muted.
Thank you. Oh, I'm unmuted now.
Yes.
Can you hear me?
Yes.
Yes, yes, yes.
Right. Of course. So hola, kia ora, and greetings from New Zealand. Thank you for the opportunity to join you today. And I will talk a little bit about telehealth and how that relates to opportunities for leadership in nursing. And right now I'm not getting any, there we are. So why we need telehealth. The problems are the same around the world. We do not have enough health professionals and we do not have them where we need them. And Carla was saying about the south area of Chile, where you have a lot of rural people living. But people, wherever they are, should have equal access to health services. We also have an aging population. People live longer, and with that, we have a higher incidence of long-term conditions, which means that they need more care and over time. And we also have a move from secondary care, recognizing that hospitals only provide part of the healthcare equation, and that in fact, most care occurs in the community and closer to where people live. So how do we manage these issues? So alongside, as Viviana was saying, the pace of change is increasing. We have more opportunities, and technology is one way to help improve our efficiencies. Because the bottom line is that healthcare takes more money than most countries can provide. And yet the need just keeps on increasing. So more people, more need, not enough money. How do we work smarter? And using ICT is part of that solution. So there are opportunities to use digital technologies to provide data for nurses wherever they are, alongside their patients. So rather than having to go back to a central clinic or be hospital-based, you can actually have the data available at the point of care. If we use technology well, it will help our health dollar go further. And another change that's occurring is that patients want to have more say in what is happening. And there are opportunities to support patients to manage their own health and well-being. And this can really change and transform how we deliver healthcare. So what might some of these things look like? And some of these you might want to look up later. You may already have some of these in place. So one that we see in New Zealand is the use of patient portals, where the patient can log on to a website and see their health record and see the medicines that they're prescribed. And when they need a new medicine at home, you can go to your patient portal and ask for a renewal of your prescription. It saves you having to go to visit a health professional. Alongside that, we now have e-medicines, where when I need my prescription renewed, I can go through the patient portal, ask my doctor for a renewal. Sometimes I must go in and the nurse must check me first, but sometimes it can just be rolled over. And then the prescription can be sent directly to the pharmacy, and I can just go and pick it up or even have it delivered. In New Zealand, we're having a resurgence of COVID with the Delta variant, and we've been using a tracer app. So every time I go to a shop, I must scan in and click the data on my phone so that it is clear where I have been and where points of infection transmission could occur. So that's another way of using IT. And I guess COVID has brought, along with huge change, it has also brought some opportunities. And for me, Viviana talks about the patient being central, but it's more than just for the patient, it's also for all the patients. And using ICT, digital technologies well, would give an opportunity to provide more equitable health service to patients wherever they are. So just a little about a telehealth framework. So my talk is around telehealth. And Mari Tietz from the United States created this framework, which is quite a useful way of breaking down telehealth. So she talks about telemedicine first, which is more in secondary care, so clinic-based, remote monitoring and management, and then mobile health. And you'll notice here that this has what Viviana was talking about, the wearables. that comes under the mHealth, mobile health component. Let me go for a little more detail into these areas. When it would like to. Right. So these pictures show telemedicine. So this is more in secondary care services, and you can have a nurse who is taking recordings, storing everything electronically, but then being able to communicate with other parts of members of the team, the healthcare team. So the patient can have direct communication, or it can be mediated by a nurse. You also see the example of theatre, and perhaps you have heard of this too, of surgeons doing remote surgery, where a surgeon in another country, one hopes with really good internet connection, being able to utilize tools affecting change and interaction and surgery on a patient in another total area. So those are one aspect of telemedicine. So the other one then is about remote patient management. And this is where the patient by themselves could interact with a health professional, with the nurse, and have a check-in, have a clinic appointment. Or also that the nurse could be alongside the patient, where they both talk to a specialist, so that the patient is not trying to manage the conversation by themselves. The nurse can have already assessed the patient, then hand over, perhaps advocate for the patient and help the patient ask the questions to get the answers that they need to be able to live their lives as well as possible. And then there is mobile health, where you can have devices that can either send the information remotely to a central place where nurses can view that data, but also for the patient to be able to see what they are doing and how they are trending, and therefore have more chance to understand what is happening. So telemedicine, there's the telesurgery example with robotics as well. And you will always have nurses involved as part of that, taking good care of patients and making sure safety is maintained. There's also opportunities for teleeducation, so that if you are working in a more remote area, you do not have to miss out on educational opportunities to keep up to date. And you can use the telemedicine tools of video conferencing to keep you connected and your professional development ongoing. Teleradiology, and in New Zealand, and teledermatology. In New Zealand, we use these because perhaps a bit like Chile, we have the city centres where most of our expertise lies and our big hospitals are, but we have rural areas that are not as well served. And so being able to call on the expertise of specialists, of more senior nurses, can help you provide better care and know that you're doing the right thing for your patients. And then you have that teleconsultation. So you can have the patient by themselves taking their blood pressure, and then they can see the result and talk to their health professional at the same time. You can have the nurse communicating with their patients. And I think for all of us during COVID-19 and the pandemic, and being concerned about the risk to others of becoming infected, that one of the main means of communication is not necessarily the video conferencing, but back to the ordinary telephone. So whether it is a landline or it is your mobile phone, that works just as well to help people stay connected. And there are opportunities, and nurses are learning how to expand the skills they already have. I believe nurses have most of the skills already to be able to practice telehealth safely and well, and to meet their patients' needs, because it still comes back to that personal connection you have with your patient. So the difference might be that instead of doing it face to face, as the picture here on the bottom right of my screen, you could do it remotely through video conferencing using a computer or just a tablet. And the mobile health applications. So this allows people to see and to manage their own health, but also for some of that information to be shared with health professionals. And so that allows us to monitor our patients wherever they are, and to be able to see trends and to be able to make contact when we see or notice a change that is less than desirable, so we can have early intervention. So mobile health, there's so many apps out there for those with smartphones, and lots of ways through either applications or through wearables like your watch that you can keep up with how your health is trending. I haven't seen any of these fancy glasses yet, but the watches are fairly common now. No doubt you have seen them too. So what do we need to make this work? For a start, we need a shared understanding about what we're trying to achieve. And I guess Viviana and Carla were both intimating about the need for ongoing education and keeping up to date. We need a shared language. We need to understand the terminology of what we're talking about. We need consistent data, that not entering measures like blood pressure in a text field where you can have it put into a field where you can then graph and see trends and changes over time. Ideally, as in large areas, we will have shared data sets. In New Zealand, we have a national health index, the NHI. So we have everyone in the country has the same, has a unique identifier. We also have a national provider index so that each nurse and each health professional has an index number so that we can share the records, we can keep track of who is having services, who is providing the services, and it allows for tracing this wherever the health professional is working or wherever the patient turns up for service.
2 minutes.
This supports things like shared records and immunization records, and I've said updated for COVID-19, because of course that's the obvious example. Not only do you need a shared record, you want to know who's vaccinated, when they were vaccinated, and what else might be needed. So for all this to work well, we need interconnecting IT systems. So wherever you are, you can have the healthcare that you need. You can provide the healthcare that your patients need. We would hope in the future to have more and more consumer involvement, self-management, keeping yourself healthy so that actually we can reduce the healthcare needs. And that will take all of our engagement. Every health professional needs to be engaged with what is happening with technology, and that's about taking personal leadership so that you're ready for the future. I've listed a few resources here that may be of interest, and I think perhaps this will be available later. We can get a copy of this, my PowerPoint later, and I look forward to hearing of any questions that you have. Thank you for your attention.
Thank you, Michelle. Your great presentation. It is a great example for us. Okay, vamos a
Okay.
agradecer, ¿no es cierto?, a la doctora.
Thank you, Dr. Hanir.
Y recordamos que pueden escribir, por favor, sus preguntas.
We thank Dr.
Hopefully,
Honey.
you'll be relaying your questions
Para poder hacer las respuestas a esta.
so that we can field them for the roundtable.
Y para finalizar, tenemos una gran invitada.
And finally, we have a renowned guest, Stephanie Avendano. a specialist in intensive care, adult intensive care, member of the nursing division of the Chilean Society of Intensive Medicine, and clinical nurse at the Catholic University Hospital. Her talk is on the implementation of remote counseling during the pandemic.
I am specialist in intensive care as a nurse, and I'm adjunct instructor in the School of Nursing. And I'm going to tell you the way in which we implemented the remote advisory model in the first and second big waves we had in the country. We have to remember those very sad images when everything started in December 2019 with the outbreak in Wuhan in China. Unfortunately, those numbers grew case by case in Europe. In January, February, we were somewhat cautious. We kind of suspected what was going to happen in Chile, and the WHO declared the pandemic of COVID-19 on March the 11th, 2020. This was by WHO, and we thought that this was going to be quite big. Regarding ministerial strategies, the Ministry of Health joined with the Chilean Society of Intensive Care Medicine, and they both together with this external advisory established the Hospital Digital, digital hospital. The purpose of this hospital was, well, vis-a-vis this increase in cases, patients that needed mechanical ventilation, patients that required expert staff to take care of them. Well, the purpose of this Hospital Digital was to give immediate response to colleagues from different areas. The Hospital Digital established a strategy of 24/7 calls. Calls were received for psychologists, physicians, nurses, physical therapists. All of them were specialists in intensive care. As I said, SOCHIME, the Chilean Society of Intensive Care Medicine, they are a reference. They help implement several strategies. The main objectives were to be able to train the staff and make the necessary documents for support, align management and support therapies nationwide. We know that geographically, Chile is quite a long country with important barriers. So aligning the way in which we were going to deal with intensive care with specialists that were not in the area of intensive care was something very important. Also, we had to educate and inform the population at large. We were experiencing a pandemic where educating the population was the main tool we had to ensure that contagions could be avoided. And they also advised the healthcare teams in a most concrete and rapid way possible. Experience in Chile. We knew that COVID internationally responded, or rather was respiratory distress that responded to prone positioning, high flow, and the same thing for non-ventilated patients. So we can say that there were three important moments, three milestones that were so important to provide care continuously during the first and second outbreak. A full program was developed for the critical care patient through classes online, symposia, with the participation of experts in the area.
They'd look at the different subtopics, all online and with the social networks. With the digital hospital, we had telehealth care with intensive care specialists in an ongoing fashion 24/7, at least during the first outbreak. And the emphasis of the topics with these different strategies were things as basic as use PPE, invasive mechanical ventilation, how to manage a ventilator, how to operate one, with the different kinds of technologies that we had in ventilators to instruct colleagues that were using them. We were educating the entire country in that matter, high flow nasal cannula, and pronation. For the second outbreak, throughout the first outbreak, the main goal was to get the highest coverage of non-expert professionals in ICU, because we had to not just double the amount of ICU beds, but quadruple them. And we needed quick orientation to the team that wasn't really specialized in ICU, in intensive care, in an area which they probably might not have ever seen. For the second outbreak, now we put together a registry where we looked at the centers with the greatest need of care. And these were extended ICUs. There were ICUs that had been implemented during this outbreak, which pre-pandemic hadn't been ICUs for surgical recovery post-op, ORs as well, specially dedicated areas which ad hoc places which had been used for other purposes. Sometimes these were implemented on a province-wide basis. So in this second outbreak, we had telemedicine together with a physician and specialist nurse, and we sent them to a specific center to look at any concerns coming up with these newly implemented ICUs, these extended ICUs that had been newly created out of ad hoc spaces. We also had on-site visits from experts to these centers, the ones that needed the greatest amount of care. This, which was defined by the Ministry of Health, or it was also through ongoing evaluation. This is how they could evaluate needs that would come up over time, and to be able to perform a pre and post registry, and to look at the counseling to see if they were, as an auditing process, to see if they were effective. Now, my experience was in the deep south, the Magallanes region, to Patagonia. It was at an extended ICU opened in Punta Arenas. And we know that, correction, Punta Arenas, you know, it's the capital. I was at Puerto Natales. And there was only one hospital in the capital with an ICU. And it was a medium complexity, not high complexity. The extended ICU that was opened at Puerto Natales, away from the capital, was for post-op, that new ad hoc center. And from February to June 2021. And in March, all the way up to May and June of this year, we had our second outbreak, almost throughout the entire national territory, from north to south. And this place received patients transferred from the rest of the country, from all over, from the center actually down. So if they were sent to the capital, for example, and if Punta Arenas could not receive them, they would be referred to this ad hoc ICU. So there's a significant geographical barrier. You know that in Patagonia, we've got fjords, places that are cut off. We need air transport to get to some of these places. Transport is also cut off during for periods of the year due to weather. So here we had telemedicine provided twice a week by an intensive medicine specialist based on needs. Here are some images that I'd like to share with you from the first visit we had on site at the Puerto Natales Hospital, the ICU that was open there. On the right, where you see a patient when we extubated her. And something as common ordinary as extubating a patient from ICU. There, it was the first time any of these people were involved in something like that. A lot of them worked in post-op recovery and basic medical services. They'd never seen a hemodynamic monitor before, many of them, much let alone a mechanical ventilation unit. The second on-site visit was in May of this year. And here, multidisciplinary teamwork is key. And with Loreto, who was our intensive clinician, who had residents. We had intensive medicine residents. And there wasn't really any medical specialist on site before we got there in intensive medicine. So our on-site visitor in intensive medicine really took charge. So that's to give you an idea of the magnitude of the breach in healthcare. Here was International Nurses Day, which was special for us, which was special given the pandemic. And here you have some images of us. Now, a lot of lessons can come from this. I'd like to go over two quotes from people who have studied emergencies and extenuating circumstances. What we saw worldwide was something that really caught us off guard. No one ever really thought that this would happen. There wasn't even any plan in place because we hadn't planned ahead for it. So all of the sectors, economy, government, social areas, healthcare, everything had to reinvent. We all had to reinvent ourselves in order to gain access to the technology we had on hand for innovating the healthcare programs, of being able to examine our patients wasn't as possible as before due to lack of staff, due to the contingency, due to the healthcare needs, which grew exponentially at the time. And because we were dealing with a contagious organism pandemic through contact. So skin to skin, to be able to examine a patient was not really easy to do as before. Here are two quotes. All emergencies accelerated processes that were already in the pipeline. It's something we've already seen. And crises, just as wars, make history advance quicker. Now, what can we conclude from this model that can be implemented nationally? This is a multidisciplinary work with teams headed by professionals who are specialized in the area of intensive medicine. So they were the key intensive medicine specialists to create consensus documents prepared based on guidelines, based on evidence, and put together by an expert panel from international experience. Because if we didn't have a range of treatments, and if you have a bunch of treatments, but you have no one to guide them or direct them, well, then you don't know where you're standing. We also learned that educational collaborative strategies, remote strategies supported by telecommunications technologies was helpful in our learning process in terms of disseminating the most effective strategies to be able to provide orientation, education, and follow-up to our peers and back and forth. I think there's still a gap in that area, even with the experience we had when it comes to making this 100% remote. And it's very important for the critical care patient when we need on-site follow-up and orientation with this dual modality that we perform. Like I said, remote and on-site. Now, how we would adapt to this emergency and to active detection of needs, understanding orientation education as a dynamic process. What we needed yesterday is not the same as what we need today. Here are my references. And that's what I had to share with you today. Thank you very much. Thank you, Stephanie. Wonderful experience you had, a life experience, and what a collaboration, what a contribution in the Deep South. Very important. And we have to keep going, as you mentioned, taking into account the technology we have at hand. They have to keep helping us, and they have to keep being a tool for better disseminating know-how throughout the country. Now, before, I'd like to invite you to leave your contact information by clicking on the link of our YouTube stream, so you can get information from all the webinars, which will be available, workshops and the talks were part of our academic extension. We'll be moving on with our Q&A. The dynamic will be as follows. I'll be relaying some of the questions. We'll be seeing who is most interested in responding. We have Marcela Faundes. Studying in Chile is expensive. A lot of it's resource intensive when it comes to postgraduate studies. Now, in the new generations, we'd need these topics would have to come to the forefront of information technology, of medical IT in the undergraduate curriculum. What is your opinion on that to the panel? I'd like to see, Vivian, your experience and how Michelle Honey is also sees this at her institution. So the mic is open. Whoever wants to chime in may chime in. To field that question from Marcela, it's important to emphasize that on the national level, there's a deficit of human capital in clinical IT, informatics, to impart this in an undergraduate fashion. Now, the Catholic University, where I work, already created a revision of our curriculum, and from starting next year, there will be 2 to 3 courses as part of the undergraduates of informatics and healthcare. IT 1, 2, and 3 in healthcare. So for the Catholic University, we've got trained personnel there. You can perform those updates in the curriculum. But on the national level and other universities, there is this demand. So anyone who's interested, hopefully you can become trained in this, so we can spread this to other institutions. That would have been the Catholic University's experience. So right now we're doing it postgraduate, but the idea is to make it to transfer to the undergraduate. Thank you. Michelle? Could you give us any comments?
Yes, thank you. At the University of Auckland, we have gone for an integrated approach. So informatics, nursing informatics is throughout a lot of aspects of the program. So when you learn communication, you learn that whether it doesn't matter whether it is face-to-face or electronic, the rules that apply. When you learn about law and ethics, the ethics and law and statutes that relate to informatics are taught at the same time. And then when our students go to clinical, they see different technology in place wherever they go. So rather than have it as separate courses, we've built it in throughout the whole program at the undergraduate level. We have postgraduate education for informatics. Not so many nurses take it. They often want to specialize in their area of practice. And some will, like if you work in intensive care, Stephanie, you gave so many brilliant examples. So then they might do study on what is the impact of increasing technology on nursing practice. But then they do it from their specialty area with less of a focus on informatics. So in some ways it becomes a little invisible. But on the other hand, more positively looking at it, it means that informatics is part of nursing. It doesn't have to be separate all the time.
Thank you. Interesting. Okay, siguiendo con
Right?
otra pregunta que,
Another question has come in
Marcela Faúndez.
from Marcela Faundes. Yes.
Si es que hay alguna
If
guía
there are any guidelines
que pueda orientar
that can provide orientation
intervenciones
in the
sociosanitarias,
socio-healthcare interventions,
vía telefónica,
be it by telephone
videollamada.
or by video call.
Si es que hay lineamientos, si es que hay
If there is alignment, if there are protocols in place, I could field that. Apart from working at the Catholic University, I'm also part of the quality area of the National Center of Informatics and Healthcare. Last year, in 2020, during the pandemic, when this upturn in healthcare, IT, and telemedicine came up, we had the first guidelines of good practices in the use of best practices in use of telemedicine associated with teleconsultation and telehealthcare, telemedicine that you can find on the Sense webpage, which is a public access. You can download it, no cost at all. Sense.cl. And they're working on the update of the best practices guideline in their second version, a bit more streamlined post-pandemic. We're still in the pandemic, but we have better figures.
Perfecto. También ella hace una pregunta acerca
She also asks about
de la clasificación
the
internacional.
International Classification of Diseases, ICD.
Debemos actualizar
I believe that we need to update ICD
ingresados en los sistemas públicos.
that are in public systems.
¿Estos se pueden codificar de manera
Can
más
this be
adecuada? Esta es una pregunta que
coded in a more
yo
precise
he
manner,
tenido oportunidad en distintos tipos de
more narrowed down?
Cuéntenme, ¿qué opinan ustedes?
What is your take on that?
Well, I think there is ICD-10, and now ICD-11 is coming. So there is already work internationally. So it's a very good question. You're just a little ahead. But I think that there is work internationally to look at it. And it won't focus on COVID because COVID is just the infection. It will focus more on what is the impact on the person. And I think that is the kind of detail that nurses are looking for. How it affects the person and hopefully also, you know, they're not just the physical aspects, we have yet to explore what it is going to mean for long COVID and long-term rehabilitation. And that will have more of a social and cultural impact on people, and economic as well, no doubt.
Okay.
Sí, a mí me gustaría de todas formas también complementar lo que
I'd like to tack on to that. We also have to take into account that within the informatics systems now, we have the classification of ICD-10 in order to reach diagnoses from the medical point of view. However, we have to acknowledge that ICD-10 is an international classification of disease, but with mainly for measuring for statistics of mortality. We won't be finding diagnoses associated with patients, healthy patients or control patients. So that's where you see the complexity among clinicians and when able to find out what kind of code which can apply to a clinical assessment that's being performed currently. And here the important is to move forward in implementation of terminological servers such as SNOMED, which is more clinically focused. And it also takes into account healthy patients. So we're waiting for the system update in order to get to work. The Ministry of Health is working on updates or in the translation of SNOMED, which is also comes from the international level. There's also certain codes, but not all the systems have been properly updated. So due to the pandemic, it's very necessary to control and we hope that hopefully we'll be able to use these technological servers. But also as nurses to be able to get to diagnosis that pertain to nursing.
Muchas gracias.
Thank you very much. As a thought from one of our participants, despite the fact that information technology and everything doing with medical informatics, innovations, now this is in the midst of the pandemic, which was a driving force, which was positive from one point of view, to look at traceability of data. Now, how would this traceability be on the population-wide level? What are the technological tools, taking into account that every 100 years we're hit with a massive pandemic? So we're in 2020, well, almost at the foot of 2022. Would be the health technology that governments manage when it comes to quantifying patients that are infected, how to perform telemedicine in order to avoid spread at health centers. Participants say that this has been a driving force for innovation, a boost that made it possible for all of the people who are working in this area to explore, to develop information technology in our country, as well as in the world. We can see that in Germany and in other parts of the world. We have apps where you can assess how many steps a patient performs from one day to another, breathing rate, heart rate, and you can even surmise whether or not they're infected or not based on data such as that. So they get that data, an alarm goes off. They said, you're on this up, your heart rate's down, your amount of steps per day has gone down, breathing rate's up. So we'll be looking at your temperature, PCR test to rule out a positive case. So this was seizing the moment, opportunistic.
Así que bueno, yo creo que es una oportunidad ante un caos, como en algún
So this is an opportunity in this rather chaotic situation. I don't know if you have anything to add, anyone from the panel. Fortunately, these things happen. Unfortunately, these are times to act.
Y si es que estamos okay.
And well, all right. Without more questions, we can wrap up this webinar. Thank you to all of our renowned speakers, Michelle, Stephanie, Viviana, for being with us, for taking time, for sharing your know-how, for this contribution to the community, to rekindle our interest in informatics, especially as it pertains to healthcare, everything having to do with apps, device, AI, this new world. So we hope you can share this webinar with your colleagues, people in the healthcare area. I'd like to remind you that the English version is available starting from tomorrow and the YouTube channel from the nursing school from the Catholic University. So once more, leave your contacts so you can receive all the invitations and the extension activities for ongoing education from the nursing school. Thank you very much for being with us. May you have a wonderful afternoon and a wonderful week. And thank you once more for being here with us.